Good evening, everybody, and welcome. This evening we have Vladimiro Silva joining us, and we are going to be talking about PGT A genetic testing in patients over 40. And Vladimiro will introduce himself shortly, but he is the director at Ferticentro Fertility Clinic. So, Vladimiro, would you like to tell us a little bit about yourself?
Well, hi, Rachel. Thanks for the European Fertility Society for having me. It's always a pleasure to participate in these webinars. So talking a little bit about myself, I'm originally a pharmacist. I used to be the lab director at Ferticentro for almost 20 years. Now I'm the CEO of the group. We have a group of clinics with 3 clinics in Portugal, 3 in Denmark, and 1 clinic in Greece. And so today I'm speaking here in behalf of Ferticentro. So I'm someone who is passionate about the science, about the topic of IVF. I spent a lot of time talking to patients, and I always like to do these webinars, and I'm very engaged in the scientific development of our clinics. So I will do my best to share some knowledge on IVF, obviously, and PGT A, and then I will try to make it short. Please tell me if I'm pushing too hard, and so we can leave time for the Q&A, which I believe it's the most interesting part of this.
Yeah, absolutely brilliant. Thank you. So yeah, just to anyone who is listening, you can type your questions in the chat. It is anonymous. I will wait until the end of the presentation before we come to the questions, because you may find that Vladimiro answers your questions throughout the presentation anyway. So there will definitely be an opportunity at the end. But I believe you have a presentation for us, Vladimiro.
Yes, I will start by sharing my screen. Hopefully this will work. Like I said, I'm speaking in behalf of Ferticentro, also on Procriar. So on the topic of IVF and genetics, one of the questions that we always ask is kind of, what can we do? I mean, we can talk, okay? We can talk a lot. We can counsel the patients. We can try to create the best possible embryos, and IVF and genetics is all about testing the embryos, not to change the quality of the embryo. So IVF, our technology, at least nowadays, doesn't allow us to transform a bad embryo into a good one, but we can know whether the embryo is good or bad and make our decisions around it. We use this to prevent the transmission of genetic diseases, to screen for the potential of genetic problems. Some of them are age-related, and obviously there are also situations where we use IVF genetics to find HLA-compatible embryos in very special cases. This is not the topic today. I will be talking about PGT-A. This is the acronym for pre-implantation genetic test for aneuploidies. There are other types of pre-implantation genetic testing, which will not be the topic today, so I will not lose your time talking about them. This is a test that is performed on embryos to screen for numerical chromosomal abnormalities. This is what we call an aneuploidy. So these are embryos with an extra or a missing chromosome. These embryos, often the ones with an extra or missing chromosome, they fail to implant. They can lead to a miscarriage, or if the implantation is successful, we can have the birth of a child with a genetic condition. Embryos that are chromosomally normal are referred to as euploid, and are the most likely to lead to a successful pregnancy. We do next generation sequencing, where we analyze the 24 chromosomes. This is the most developed technology available, and so this is, like I said, this is not to increase your chances of a pregnancy. It's a very important message, because it won't make your embryos better. It will give you more information it will tell you the truth, whether that embryo is viable or not. It will increase our capacity to select the best embryo, and it can reduce the number of cycles needed to obtain a pregnancy. Okay, so this is an information tool, a decision tool. Okay, we need to be very focused on what PGT is and what it is not. Okay, one very important information before starting to talk about this is what nature gives us. And we can see these are data from Cooper Surgical, one of the main companies in this field. And you can see on the red bars the likelihood of an embryo being aneuploid, meaning with chromosomal abnormalities, according to the female age. And we can see that above the age of 35, it starts peaking, and obviously the probability in the green bars of an embryo being euploid, meaning with the right number of chromosomes, starts decreasing, and it drops more steeply after the age of 35. Okay, this is what nature gives us. Okay, that's with this that we need to work. These numbers were obtained from a sample of 125,000 embryos. Okay, and obviously this is from another lab, in this case iGenomics. We can see, for example, the probability of an embryo being aneuploid on an IVF cycle according to maternal age. So we can see that the lowest is between egg donors. 37%, roughly speaking, of the blastocysts are aneuploids. But then when the female age starts to increase, we can get to as much as 76%. In Portugal, we are allowed to do PGT A without any other indication above the age of 37, and so that's what we do at our clinics. And obviously also in other situations where patients, for example, had 3 previous failed embryo transfers, where they had a miscarriage, 2 miscarriages, or maybe, for example, a previously affected pregnancy where an abnormal embryo was found. For example, a miscarriage or leading even to a termination. Okay, and then this is another set of data from Cooper Surgical about the probability, the percentage of patients to have at least one euploid, meaning one viable embryo for transfer at any age. So we can see that according to their statistics, if you are, say, 40, which is the topic today, above 40, in order for you to have a 90% probability of having a euploid embryo, you need 7 to 10 blastocysts, which is very difficult to get, and you still have only an 81% probability to have a viable embryo. And obviously, having a viable embryo doesn't mean that you will have a viable pregnancy, because then there are other factors like the endometrium and so on. So this is what nature gives us, and this is the information that we need to make decisions, to help patients planning for their treatments, setting up goals like, okay, I'm in this age group and I want to be here, or I'm happy to be here. I mean, each person has its own goals and preferences, and obviously this also costs money, so this is also a factor that we need to consider while discussing all of this information with patients. Obviously, we know, and this is again data from iGenomics, that when we transfer a euploid embryo, and this is what we have on the gray bars, we have almost 60% of pregnancies, and it is roughly the same across all ages, while when we have an unselected group of embryos, which is what we have in the orange bars, we can see that the pregnancy rate declines with the female age. Okay, obviously this means that when we transfer a genetically viable embryo, the factors that impact on its capacity to implant are more related with other factors or with factors other than aneuploidy. One of the questions that a lot of patients ask us is whether, okay, but can PGT A make us reject viable embryos? This is a very pertinent question, because there were several studies, especially some studies in the United States have shown that after PGT A, there were embryos that were considered to be abnormal, and then ultimately they were transferred, and there was the birth of healthy children. Okay, that happened, but we need to compare the level of technology that was used at the time and the study conditions. Okay, there are several questions on how accurate was the PGT-A performed in those cases. To solve this question, a very important group, the group from IVI in the United States and the Yale School of Medicine, one of the most important universities in the United States. They did this very large study of 2,600 embryos where they did the biopsy and they transferred these embryos without knowing the result, okay? And then what did they found? They found out that they transferred 2,600 embryos without knowing. I mean, they did the biopsy, but they then transferred them into the womb blindly. We could see that the group of embryos, and lately they went to see the results of the PGT. Later they went to see the results of the PGT-A. They saw that when they were transferring a euploid embryo, euploid, the viable one, the positive pregnancy test rate was 82%, while with an euploid, so an abnormal embryo, the positive pregnancy rate was 40%. But the most important number is here, which is the delivery rate, the live birth rates. And what have they found is that when they were when they were looking only into the babies that were born, 64% of the viable embryos, the embryos that were found to be viable through PGT-A, led to the birth of a healthy child, while 0% of the embryos that were found to be abnormal led to the birth of a healthy child. Okay, so this shows that, okay, it could have happened in some cases in the past, but in a very large sample, on a study that was controlled by one of the best universities in the world, okay, the University of Yale. So a study performed in ideal conditions. It is a sample of 2,600 embryos. We can argue whether this is, I think it's a very big sample, but okay, it is what it is. So they found not a single case where an abnormal embryo and an aneuploid embryo implanted and originated the birth of a healthy child. Okay. Another question that we get a lot is from patients is, can the biopsy damage my embryos? From the same study, the answer is no. Okay, on the blue bar, we have the embryos that were biopsied, and then they compared with a control group with 1,208 embryos that were not biopsied. And they saw that the pregnancy rate the implantation rate had no differences. So it was actually slightly higher, but with no statistical significance in the group that was submitted to the biopsy. And so this is why nowadays, with the level of technology that we have, we can say that the biopsy doesn't damage the embryos, okay? Because it is done at the blastocyst stage, embryos that are day 5 or day 6, so the embryo is very resistant, and obviously it needs to be done properly with the right type of equipment and with very skilled and experienced embryologists. So going to the patient stories, these are obviously fake names. This is patient number 1, Joanna. When she came to the clinic, she was 42 years old, single, never tried to get pregnant. She had a normal BMI and an amazingly high AMH, 5.1. Okay, the ovarian hormone, the other hormones were fine. FSH RH 6.5, LH 6.3. We did a kind of aggressive stimulation because of her age, 300 international units per day. We had 9 eggs, which is not too much given the level of AMH, and we ended up with 2 day 6 blastocysts. We waited until day 6 because we weren't so sure about the quality of the blastocysts, and then it turned out that one of the embryo was aneuploid, so not viable, and another one was a mosaic. It had 30% of abnormal cells and 70% of normal cells. So this is considered, according to the classification of ESHRE, the European Society for Human Reproduction and Embryology, as a low-level mosaic. Okay, we did the frozen embryo transfer, and we had an healthy child that is already born with a normal karyotype. Okay, so this is an example of, nowadays we consider that low-level mosaic embryos, so embryos with the level of mosaicism below 40%, are have the same probability of live birth as the euploid embryos. Okay, so this is an example of an embryo. The patient was concerned. Obviously, she received genetic counseling. We talked a lot. We work with medical geneticists, so doctors whose specialty is genetics, and so this is how we treated this case. And then we had another case. This is actually an interesting case because it mixes 2 types of PGT. This lady, she was 40 years old when she arrived to the clinic, a normal BMI. She was a carrier of a genetic disease that is autosomal dominant, so the disease had a 50% risk of transmission. We did the pre-implantation, the pre-PGT test to prepare the genetics lab. We did a first stimulation with 5 eggs. We frozen those eggs, and then a second stimulation where we got 29 eggs. So same dosage, same patient. We changed the type of gonadotrophin. The ovarian response was a lot better. Sometimes it happens. So we fertilized all 34 eggs. We had a 100% survival rate for the frozen eggs as well. So we had 22 embryos, 13 blastocysts, and then we tested 7 were not carriers of the disease, and then we did the test on the number of chromosomes. So the first test was to detect to check whether these embryos were carrying the disease that she was a carrier for, and the second test was to see if she had any age-related problem, because remember, she was already 40 years when she was doing this. And so 6 of them were viable, which is fantastic. She had a healthy child. She still has some embryos frozen. Okay, and then another case. This was a 42-year-old patient. She is single. She never tried to get pregnant. When she came to us, she had a very good AMH without PCOS. 3.2 is a brilliant value. We did her an excellent ovarian stimulation, 15 mature eggs at the age of 42. We don't see that every day. Apparently great results in the lab, 14 embryos, 10 blastocysts at day 5. And then we had the problem, because when we did the PGT A, all embryos were aneuploid, so not a single one of them was viable, and so they were not transferable. We discussed it with the patient. Obviously, she had several sessions with our genetic specialist, and the patient considered the possibility of transferring the lowest risk embryos. We explained to her, for example, a trisomy 21 is considered a high risk embryo because the baby can be born, and so it's preferable to transfer embryos that carry abnormalities that are not compatible with human life. But then the patient understood the odds. It's a little bit like what I was showing in that more recent study, and so she went up to do egg donation, and that was her decision. And this is an example on how PGT A can actually help, because without this patient would have transferred 10 embryos, okay? And she did not a single embryo transfer, and she moved on with her life. And instead of losing time and money and hope and energy with a lot of failed attempts, because as we've also seen in the first study, that's what would have happened if we transferred aneuploid embryos. And that was it. I think
Great, thank you, Vladimiro. That was really fascinating, and particularly that patient 3, I think, was a really good example of how doing the testing can reduce the time to pregnancy, because can you imagine if she'd transferred those embryos, the situation been
exactly.
ongoing.
So I wanted to show the two sides of it: success stories, and also when things don't go very well, but PGT is still useful. Okay.
Yeah, absolutely. Absolutely. So we've got some questions. Some of them you have answered already through the process of the chat. So I'm just going to select some ones that people have come up with that haven't been answered. This is a really interesting question. Someone has asked, is it the woman's age that means that older women tend to have less euploid embryos, or is it more to do with mitochondrial energy? And if you can improve mitochondrial function, can the embryo correct itself and become euploid?
Well, it's a very good question indeed. Clearly, this person has studied the subject. So what do we know about that? So the first answer, the most immediate answer, I would say, is that we don't know. There were some studies that were done in the past few years. For example, there's this very important study from Nuno Costa Borges, where what they were doing is this: they were collecting the eggs from an egg donor. They took the nucleus of the cell from the egg donor and they replaced it with the nucleus of a cell from a patient. The inclusion criteria for this study was only patients with a lot of terrible results. I think it was at least 5 or 6 failed attempts so the worst possible prognosis patients. And what was the purpose of that study? To see if the mitochondria of young eggs, so donor eggs, were able to repair the DNA of these older patients with a history of terrible results. And the results were amazing. So they had 7 or 8 babies born from this study. They only did, I think it was 25 patients, was like the worst possible prognosis patients. All of these patients were considering egg donation, and 7 of them ended up having kids with their own. This is still a very experimental study, okay? This is not something that can be offered everywhere. Even the group that did this study, they are not allowed to offer this routinely. They've been contacted by thousands of patients worldwide because there are still some fine-tuning needed, even from a regulatory standpoint, because this was a study. The baby had DNA from 3 different persons, because the mitochondrial DNA was from the egg donor, the nucleus from the patient, and obviously the male partner. So it's one of the so it's a challenging question. My answer to Catherine is we don't know. I believe that maybe in 5, 10 years, we don't know. But the answer to this will be yes. But I would say not yet.
Thank you, Vladimiro. It's amazing that the amount of research and how fast-moving this area of medicine is, right? I can't believe that study sounds incredible. So next question. Someone is giving a little bit of background information. So they have had a previous miscarriage with trisomy 21. That was a natural pregnancy. They've then undergone IVF, and they've managed to get 1 euploid embryo. Unfortunately, one was trisomy 16, and they're considering to have another fresh IVF stimulation. Their husband is mosaic trisomy 20 deletion, and they're asking, what are the chances of another trisomy 21 or trisomy 16 embryo? I think age, you need someone's age to answer that question.
Yeah, That's the most important one. Let's see if this person indicates her age elsewhere.
If that's you that's asked that question, just pop your age in the box, and I can let Vladimiro know someone's typing. So
I can also, well, someone is writing. I don't know if it's her.
40.
I will not say her name. 40?
40, yeah.
Okay, very well. Okay, let me just put the question back here. So this person had a trisomy 21 after a natural pregnancy. Then she did PGT A, and she had a trisomy 16, and then euploid embryo, which is a good one. And so, and the husband, he is a mosaic himself. So the first he has a, I believe, probably a chromosomal 20 deletion, because it says T20. It wouldn't make sense this way. My answer here is this: the reality is that we would need to do deeper studies to understand, first of all, whether these abnormalities come from the male or the female part. Nowadays, it is already possible to do a PGT-A and understand if there is a chromosomal problem, an abnormality, whether it comes from the father or the mother. Okay, we're already doing that at our clinics. It's a new type of PGT-A called PGT Complete. That information, I would say, is very relevant, especially because there's an issue on the male side, okay? And while making a decision, this could be a parameter to consider. Another important thing here is, I mean, if this lady is 40, she's at risk, like we saw in the statistics that I've shown. So I would say the chances of having an abnormal embryo, regardless of the abnormality found, are the ones specifically related to the age of 40. And for that, I'm just taking a look at my numbers here. At the age of 40, I would say it's around 70%. Okay, 70% of these embryos have abnormalities. Having a blastocyst, 70% of the blastocysts, okay, because sometimes we don't have blastocysts, or we don't have good quality blastocysts. So when we have a blastocyst, 70% of them are abnormal. So maybe the answer to this question is 70%. But before that, I think we should take a deeper look into the origin of the inequality, because I think that's very relevant on this particular case.
Yeah, absolutely. Thank you, Vladimiro. So someone else is asking, they had their embryos frozen already, and they then thawed them to be biopsied, and then they were refrozen. And they're asking whether that you would then recommend that embryo would be suitable for transfer, which is
this is something that we do more and more. Okay, this is obviously, sometimes we don't do the PGT-A because the patient doesn't want, for various reasons, and then we start transferring the embryos. We don't get good results, and then we will go and biopsy the remaining embryos. We had lots and lots of pregnancies. I can't quantify at the moment. This is routine nowadays in, I would say, most developed IVF clinics. You need to have a very good vitrification program, very skilled embryologists to do that. If you do have that, then you can safely do that. Obviously, the risk of losing an embryo in the vitrifying and thawing process twice, I would say overall, we used to say 2%, because that's the survival rate, 99 to 98% to the vitrification, and it's 2% each time. So you do it once, you lose 2% of the embryos. You do it the second time, you lose another 2%. On the biopsy, as we've seen in the statistics that I've shown, we're not, I mean, sometimes there are embryos that start degenerating, but I don't see a risk, a particular risk, according to our statistics and published data.
Hopefully that's reassuring for people. That leads quite nicely. I'm going to skip down actually and come back to some other questions, because that leads nicely into some questions people are asking about what criteria should we check if the lab is skilled with embryo biopsy, and what sort of, what's the word I'm looking for? Like what sort of experience should we expect the embryologist to have? Like, do they need to have a certain number of years before they would then be classed as experienced?
It's a tricky question as well. It comes from the same person. So there are certifications in embryo biopsy. For example, at Ferticentro and Procriar, all of our embryologists are certified. Or at least all the embryologists that are actually doing it are certified. There is, and so the certification comes from external entities, but obviously if an embryologist has been doing it for many years with success, the certification is just a formality. So it is more related to the number of procedures done, to the level of activity of the clinic, and all. A very skilled embryologist can start a new clinic. Okay, so it's not just the clinic; it's also the personal experience of that person. But so I would say certification is the easiest way. The second easiest way is the time of expertise. If someone has been doing biopsies for 10 years with a lot of cases, then I wouldn't be worried. It's more or less, it's the size of the clinic that's more relevant.
In that case, then, would you say that there isn't really a difference between which countries are performing kind of more accurate?
No.
It's not relevant.
No,
yet.
I mean, there are some countries where, unfortunately, for legal reasons, we can't do PGT A or they can't do PGT A. And obviously, in those places, the embryologists are not skilled on that particular technique because they don't do it on their daily operations. But aside from those situations, I would say embryologists nowadays are very good. The systems are very steady.
Okay, thank you. The next question we have is about something called chaotic embryos. And this is for anyone listening that's not sure, and correct me if I'm wrong, Vladimiro, but where they have more than 6 chromosomal abnormalities. And someone is asking, what's the likelihood for these embryos being euploid? And do you have any experience with these sorts of embryos?
That happens, obviously. So these are very low prognosis embryos, okay? I would say the likelihood we've seen on the other study from the University of Yale, that these embryos that are aneuploid, they have very low chances. They had 0 on their particular side. In medicine, we don't like the word 0. We prefer to say extremely low chances, not to say 0, but probably very close to 0 chances of implantation. These are, obviously, the more aneuploidies you have, the less, this is a sign of that something went wrong in the fertilization or the development of the egg or just the sperm. One of them had a problem, most likely the egg. It happens a lot. Sometimes we have 4 or 5 viable embryos and 2 chaotic ones. So it's just part of nature. Okay, this is a man and a woman who are not infertile, who are both 25, doing things naturally. They only have 25% chance of having a pregnancy. Why does it happen? Because a lot of the cells that we humans produce, our eggs and our sperm, are not viable. And that's just how human nature works. So it's normal to have these abnormal embryos, these chaotic embryos. I wouldn't say it's normal. It's frequent that it happens. And we just need to deal with it. And if we have more embryos, fine. If we don't have more embryos, then we can discuss with the patient whether it makes sense to try again or not.
Thank you. We have got a couple of questions about personal scenarios. Obviously, there's limited information. I'm going to read out the information we've got, and you can obviously let me know if you need any further information. But there is a patient who is 44 and has had unsuccessful IVF with her own eggs. She then went on to have donor eggs and had an unsuccessful cycle with donor eggs. She has got 2 donor eggs still, or 2 donor embryos rather, remaining. But she has stage 4 endometriosis and has had bowel resection. And she is interested to know her success rate. I guess the first question would be, are the embryos euploid?
Yeah, of course. That's the main question here. So, starting with the endometriosis, patients with advanced endometriosis almost invariably end up needing egg donation. It's one of the, I mean, it depends on the age. Obviously, endometriosis is very variable from a patient to the other. If patients are lucky enough to have their at least a part of their ovarian reserve preserved, then they could get pregnant even naturally, and so on. When the patient is 44, so the age alone is a very serious factor, and with an endometriosis, a severe endometriosis case, then it's more complicated. And this patient mentioned she had bowel resection because of the endometriosis. This means that she had a surgery. The endometriosis was starting to affect her bowel, and so the doctors probably removed a lot of it. And when it affects the quality of life, obviously it's very difficult while doing an endometriosis surgery to protect the ovarian tissue while just removing the endometriosis nodules. So it's, I would say, almost inevitable to lose some ovarian reserve, a lot of the ovarian reserve often, and these patients have a formal indication for egg donation in a case like this. Having a failed attempt with a donor egg, it can happen, okay? We've seen that around 34-35% of donor embryos in my presentation, they are abnormal. So maybe this patient was just unlucky on the wrong side of statistics. If there are still other embryos, maybe those are the viable ones. Of course, if it was possible to do PGT, then she would know whether it makes sense or not. Also, egg donors are humans. They produce viable and unviable eggs, and sometimes it's also a question of luck, because even with egg donors, obviously we can isolate groups of patients where we have a pregnancy rate of 80%, but we also have groups of patients with a 15%, 20% pregnancy rate. It really depends on a lot of factors. I would say the endometriosis, once after the surgery, because it doesn't affect the inside of the uterus, I wouldn't say it is a factor, but obviously there are exceptions to what I'm saying.
Thank you. We have another question asking about whether a 5BB graded embryo has a good chance to implant. So it might be quite good to look at this in context, sort of how grading relates to euploid rates. If there is any correlation.
It's one of those questions that we get a lot, and it's very difficult to explain it to patients. So first of all, what's a 5BB embryo? When we culture the embryos in the IVF lab, and so we have there are several ways for the embryologist to assess the embryo quality. There's the classic morphological classification, and this 5BB classification relates to that. It's a day 5 embryo with certain characteristics, and then there are a lot of variances on this. So even sometimes inside the same IVF clinic, different embryologists would classify the embryos differently, even though they learn together, they work together side by side, because it's just a human thing. Okay, obviously we try to be as objective as possible, but still there's some room for interpretation, sometimes even the position of the embryo. And then whether you have, for example, access to time-lapse imagery. In our clinics, we only do time-lapse. We are 100% embryoscope clinics, and so we have access to information on the embryo development that is only possible to see that way, and that will help us to formulate an opinion on the viability of the embryos. And nowadays there are artificial intelligence systems that will review how the embryo develops. They see things that the human eye can't see, and then they will just tell you this embryo is the one that has the best chances for implantation, without the subjectivity of the operator, the human operator, the human eye. So after saying this and answering to this question, it is I would say it's a good classification. Okay, in principle, the chances would be normal for a blastocyst. It obviously depends on the age of the patient. If it's an embryo coming from a 25-year-old patient, even if the classification is worse, I would always prefer to have it instead of a perfect embryo from a 42-year-old. Okay, this is just how human biology works. So, and also it will depend on the moment where this embryo was graded. Like I said, with the classical morphologic classification, we're taking photos of the embryos. With time-lapse, we can see that sometimes if we want to just give the embryo the best possible classification, we can just wait a little further, anticipate a little further. It's easy to manipulate. Not to manipulate it. No one wants to manipulate it, but sometimes it will depend on the moment that we are looking at the embryo, because embryos evolve in a very dynamic way. Why do clinics still use this? Because there's no better way to communicate. Okay, I can tell a patient, well, I use the AIVF artificial intelligence score, and your embryo is a 79. Okay, or so it's difficult, because if that clinic doesn't use that, they don't know what it means. And still, even artificial intelligence scoring systems, they are still going through their first steps. So sometimes it's not very evident whether we can, all the studies indicate that we can rely on those systems, but there's still kind of maybe 1 or 2 years for us to completely rely on them. So I would say the clinic where this was done has the answer, okay, in terms of probability. But I would say that in principle, the simple fact that it is a blastocyst is a good sign. That it was graded well is also a good sign. So maybe the prognosis is good.
Very, very reassuring answer. Thank you, Vladimiro. There's a couple of questions here all about like medical efficacy, stats and trials, which are really, really good questions. I'm going to kind of group them together. So a couple of people are wanting to know, are there any cases where PGT A might exclude embryos that could lead to healthy pregnancy? Mm-hmm. And is there a higher like false positive or false negative rate of PGT A in older patients? And then someone else is kind of asking, a slightly more in-depth question about false positives. And there was a study indicating the embryo pushing the animal.
Pushing the abnormal cells outside to the outer part of the embryo.
To the outer part of the embryo. That made more sense to you than it did to me. And how to tackle that. So that's kind of like all this under the same question, really.
Mm-hmm. Okay, very well. I will share my screen again. First of all, yes, there are several studies, not a lot of studies, but there are some studies, some of them already relatively old, from reporting cases where an embryo was considered to be classified as abnormal, and then they transferred the embryo anyway, and then a healthy child was born. One of the theories behind that is because those embryos sometimes are mosaic and they have a mix of viable and non-viable cells, and they were pushing the abnormal cells to the outside and keeping the good ones on the inside, and so they led to the birth of a healthy child. That is true. That's part of normal embryo evolution. A lot of human embryos are mosaics, and they can happen. Okay, so however, a lot of these studies were done in conditions that are not as good as the ones that we have currently. For example, we now work with systems that have a huge resolution, whose resolution is a lot higher than what we were doing 5 or 10 years ago. And so we are better at identifying normal and abnormal embryos. Okay, human technology has evolved a lot. And this study from the University of Yale is, I think, the perfect example of that. So, just to remind you the story, they picked up 2,600 embryos and they transferred them into the womb without knowing whether they were euploid or aneuploid. So they didn't know whether they were viable or not. And then they got the results from the PGT A and went to see what happened to the patients. And they saw that the patients that received euploid, meaning a viable embryo, 82% of them had a positive pregnancy test, and 64.7% of them had a healthy baby, delivered a healthy baby. From the patients that received an abnormal embryo, an aneuploid embryo, 40%, even though 40% had a positive pregnancy test, none of them delivered a healthy baby. Okay, and even among the embryos that were considered euploid, some of the patients did prenatal diagnosis. None of them had a different diagnosis. So they didn't transfer an embryo saying, well, this one is normal, and during an amniocentesis it showed up being, for example, trisomy 21 or something like that. This technology is pretty solid. The likelihood of losing a viable embryo, I mean, in medicine, we don't like the words never nor the word always. So we always need to be careful, like we don't use the numbers 0 or 100, but I would say that the chances are extremely low, especially if we use the best practices and the best technology available. Okay, so unfortunately, if an embryo is not viable, I don't think there is any real chances of having a baby from that embryo.
Yeah, that study's fairly conclusive, isn't it? It's pretty black and white.
Yeah. It's obviously they indicated 0 because that's what they got. Okay, and again, it's important, the credibility of the institution, because when you do that from the University of Yale, it's not the same of being done at my clinics. Okay, because then you'll say, oh, this guy from Portugal, it's different. It's one of the most prestigious universities in the world. So this one was a very important study to clarify and it was published on the main main publication on the IVF sector in the United States. So it's a very credible evidence.
It's also a large study, right? I think you said that's a big cohort.
Yeah, 2,600 embryos. It's quite something.
Yeah. So someone else is asking, and this is a really interesting question, I think, and this is where a lot of people get confused between the age of an embryo and the age of the uterus. So does PGT A delay embryo transfer? And if so, does that have any impact on the success rates for older women? And would irregular cycles in a woman of, say, 45 plus change the recommendation around using PGT A and perhaps having that delay while you wait for the results?
Okay, so one question at a time. Does PGT A delay embryo transfer? Yes, it does, but not by a lot, like 1 or 2 months tops, because the genetics lab, so we culture the embryo until day 5 or day 6 in some countries. For example, in the United States, they do a lot of day 7 for some embryos. So we culture the embryo until, in Europe, day 5 or day 6, and then we do the biopsy of the embryo. So we do a hole in the embryo, we take out around typically 6, 7, from 5 to 10 cells, most likely 6 or 7 cells, and we send these cells to the genetics lab. They arrive at the genetics lab probably the next day, and then it takes the lab 6 or 7 days, maybe a little more if there are, because sometimes there are errors of amplifications and they need to run it again. So we have the result in around 2 to 3 weeks typically. I always tell the patients 4 weeks, just to prevent, because in some situations they need to double check the results. There are indicators that the results are not as solid as they would like, so they do that. So a month has passed, and then we know whether the embryo is viable or not, and we can start preparing the patient. So that delay will not have an impact, also because the uterus is quite resistant to the advancement of age, to the progression of age. So we normally say that the uterus stays relatively stable with the same capacity of receiving and welcoming a pregnancy until the age of 50. Our clinic in Greece, New Life, for example, they can receive patients until the age of 54, because that's the law in Greece, and obviously they need to check the patient if she's fit to get pregnant, but then the results overlap the ones of patients, say age 47, 48, and so on. There are obviously factors associated with female age that have a negative impact. The older you are, the less likely you are to have hypertension, high pregnancy, diabetes during the gestational diabetes. All sorts of obstetric complications are more frequent in among women of more advanced age. So regarding the irregular, but that's the factor that we can control. You can't go back in time. Your age is what it is. So whether you do treatment or you don't do treatment. Okay, so then regarding the irregular cycles, these are very normal. Okay, we have several ways to control it, several medical protocols that are designed specifically for women with very irregular cycles. So don't worry, this is easy. I would say almost 100% of the clinics can tackle this very easily. So this is the least important factor, because gynecologists will manage it relatively easily.
Thank you. Hopefully, yeah, reassuring again, hopefully. So another question about someone's sort of personal scenario. So someone who is age 42 and has had 2 egg collections, producing on average 4 or 5 eggs each cycle, managed to get an embryo, but that embryo is aneuploid, and they're asking, should they try again with their own eggs?
It's a personal decision. Okay, so if she's getting 4 or 5 eggs at a time, I would assume that her ovaries are still working. So yes, then obviously we need to assess how many stimulations has this patient suffered already. So normally we say until 3-4 stimulations it's okay. Above that we need to make to talk to the patient so she can make an informed decision. But yes, I would say if you're not comfortable with the decision to move to donor eggs, then that's definitely try with your own eggs, as long as you're aware of the chances. Okay, I obviously would need the AMH of this patient and a lot more information, but with this description, maybe we're talking about 5%, maybe 4, maybe 3. I don't know the quality, how was the outcome of fertilization, embryo survival rate, all of that. So we would need to look at a lot of parameters, but the chances won't be very high. If, for example, the patient says, well, it's either this or I don't try, it's also respectable, the decision of not trying, and it's also, I mean, as long as it is not impossible and the patient is aware and agrees with the risk, we can always try. And obviously, there's the legal side. We can try above the age of 50.
It's such a personal choice, isn't it? It really is.
Yeah.
There's a couple of questions about like techniques and things that might affect PGTA. So someone is asking about the actual procedure and if it's done with a laser or any other sort of tool, whether that would make a difference. To how to, I guess, the embryo is what they're asking.
Yeah, I mean, it's in the past when I started, because I started in IVF 22 years ago, so quite a long time. When I started, we were doing it with acid, with the mouth. There was also people doing it mechanically, so we were using needles to cut the embryo. We were biopsying day 3 embryos, which was a lot more aggressive to the embryo. So in those days, PGT A was not good. Okay, it was. I mean, we had to do it for different reasons, but the outcomes were nothing compared to what we have today. Okay, so these days the gold standard is the laser. I don't think there's a single clinic who doesn't use laser to do PGT. So yeah.
Yeah, I think that's definitely the case in the UK. I've not heard of anyone not using laser. And someone's asking about egg collection as well. So, and again, this might be a difference in where you're located, but they're asking whether it makes a difference to egg quality at collection, whether someone is sedated or awake for egg collection. In the UK, you to be sedated, as far as I'm aware.
Yeah, you know, our clinics in Denmark, we in our group, we have clinics in Portugal, in Greece, and in Denmark. In Portugal, it's a cultural thing, because in Portugal and Greece, all patients are sedated during egg collection. In Denmark, it's the opposite. The norm is local anesthesia. Patients are very happy with that. To be honest, I was very surprised the first time I was in the room during such a procedure. I was very impressed. I was talking to the patient actually, and she was really nice. She had 25 eggs on that procedure, and it was like nothing. It's also a I mean, it is related with the experience of the doctor who is doing it. In Denmark, and the Nordic countries, it's countries like Finland, Denmark, maybe Sweden and Norway, I don't know. But the Scandinavian countries, they do it essentially without sedation. That's the norm there. And patients even get surprised when we ask them to be sedated when they come to Southern Europe or Central Europe. It's some people prefer it more natural, some others prefer it more medicalized. It's really a question of option. In terms of the results are the same. Okay, they don't depend on that. We have some of the best clinics in the world are in the Nordic countries, and their results are wonderful. So that doesn't impact the results.
Great. I had general anaesthetic for my egg collection. I can't even comprehend being awake for it.
Yeah, you need to watch one because it's surprisingly peaceful. Okay, yeah. I thought I was, I mean, when the first time I went there, I thought, well, I will hear the patient cry and so on, but no, it was very peaceful. It was our group of clinics in Denmark is the MyGuard group in Aarhus and Odense, and Dr. Mads Reisker, he was there just very relaxed, talking to the patient while collecting egg after egg, and it was really, I mean, really peaceful, and the patient was very compliant, and it was the norm there. It's a clinic that has 900 egg collections a year, maybe more, and it's always like that.
all in the skill of the doctor, hey? So we're just going to wrap up with a couple of questions about AI and PGT A. So people are asking, does AI imaging, is it able to predict euploid status instead of PGT A biopsy? And would AI scoring, have an idea if an embryo is euploid or aneuploid? Two people have asked the same question in different ways.
Yeah.
Really good question.
I would say, so the new algorithms that are being developed for AI, they aim exactly to that. We are collaborating in some studies with a company named AIVF, and we are actually having a research project that with 2 universities here in Portugal, and then where we are studying exactly that, and the results are pretty impressive. So they are looking just at the evolution, the images, the videos with the embryo evolution, and they are looking at things like the grades of gray that they have in different cells and the way the cells attach to each other, the way they stretch while dividing, so things that the human eye can't see. It's absolutely impossible for us humans to spot that. And the system issues a score, and we've been looking at how accurate is that prediction. We use something called the area under the curve to predict whether a model is good to guess whether an embryo is going to be viable or not, and then we compare with the PGT A results, and the results are extremely promising. We are already using that, as a research tool. We're not making decisions based on that. We are still fine-tuning it, but it's a very, very, very promising pathway. I will say PGT A will remain the gold standard. We can never exclude an embryo because it has a low AI score, because it's not enough. AI imaging analysis will never replace the PGT A. Unless I'm wrong, but I don't see that happening, honestly. But it gives us for patients who are not doing PGT-A, they don't want to do it for whatever reason, it's already a tool. It's a tool that is very useful to help us decide which embryo to transfer first, even to say, to reduce the time to pregnancy, and because the system, and I don't have any doubt, if it's not already doing that, it's very close to do that, will identify the embryo that has the higher likelihood of being euploid. Okay, and if that's not the future already, it will be in 1, 2, maybe 3 years, but it will happen for sure. But the gold standard will remain the embryo biopsy with the analysis in the genetics lab.
Brilliant. Watch this space with AI, hey? That's brilliant. I'm sure everyone listening will agree that has been a really, really fascinating, informative and helpful, more importantly, presentation. Do you want to finish up, Vladimiro, by just sort of letting people know where they can find you, how to get in contact with your clinics?
Well, thank you for that, Rachel. It was a pleasure to be here. I'm speaking here on behalf of Ferticentro and Procriar, our clinics in Portugal. Ferticentro is in Coimbra. Coimbra is in the center of Portugal. Procriar is in Porto, in the north of Portugal. We have other clinics in Lisbon. I have a clinic also in Greece, Neolife in Thessaloniki, and also in Denmark, Mygard in Aarhus and Odense. So we are a little bit all over the place, but so if you can reach, my email was in the presentation. I believe it will be, if there are questions, you can just direct them to the European Fertility Society. They will kindly direct them to me, and I'll be very happy to talk with anyone interested. And most importantly, I wish thank you for listening to me, and I wish you all the best of luck. Okay, and fingers crossed for all that are in the middle of their IVF journeys. And I hope things work out for you. If you have questions, I'll be happy to answer them.
Oh, thank you. That's a super lovely way to finish. Thank you, Vladimiro. And yeah, we will speak to you soon, no doubt.
Okay.